I want to be recorded. It's time.
I'm not saying anything.
All right. So we have done most of the MS stuff. We're going to finish the MS slides and move forward to the next PowerPoint. At 2 o'clock we'll break, which is just 50 minutes, 45 minutes from now we'll break and go to the other rooms. There was a schedule up, so you know which room you're starting in. Team 1, 2, and 3 starts in 56, I think. 4, 5, and 6. I can't remember. 7, 8, 9, and 10 start here. Okay, so we did this question, so let me move forward. The nurse caring for an MS patient. Of the following medication should the nurse expect to find on the MAR, select all but apply? Baclofen, yes. Cytoxin, maybe. No. Maybe not, right? That's one of those, I don't like it. I like Baclofen. Levaquin, antibiotic, right? Plaquenil. It's for malaria. Okay. We use it for lupus, but it's not used for MS. Beta serum, that's interferon 1B. So that one is, sometimes it should be in a generic name. These actually are old questions drugged from somewhere long ago in a galaxy far away. Okay. So nursing diagnoses for an MS patient, obviously. If they lose ability to perform self-care, we'd be concerned about that. Home maintenance, urinary retention, constipation, skin integrity if they have safety concerns with pressure and paresthesias and numbness and all. Nutrition, possibly, right, if they have swallowing issues. And fatigue and sexual dysfunction, all things and body image and knowledge deficit and grieving. Anytime patients have chronic illness, grieving, depression, all those things are always on there, the psychosocial. All right, so promoting independence. We said rehab several times in the process of treatment, right? So PT and OT to strengthen, to stretch, to help with muscle balance, to teach them to use supportive and assistive devices. OT, PT, speech therapy is a type of therapy, but that's actual special therapist. That's not really a PT or OT, right? It's a speech therapist. So this is thrown in there as rehab, sorry. Balance training, obviously, is very much done in physical therapy. And for safety concerns, it'll help prevent falls. And these patients are really high risk for falls. They need a fall assessment every time they come in. All right, so there's a lot of things we do without medication, right? So we can assess our patients and teach them to assess themselves for urinary retention. If they're inpatient, we can use bladder scans and things like that, right? We can help encourage fluids because encouraging fluids keeps your kidney function healthy and going, right? Put them on a bladder training program, avoiding schedule. If you are having problem with retention or incontinence, getting somebody that will go to the bathroom every 2 hours or something like that, that can help you build a schedule and help prevent accidents. Using self-catheterization is very, very common with patients as they develop incontinence. They can do self-Foley caths, or for like male patients, they can use condom Texas catheters, right? Diapers or incontinence products that should be used by anybody that's having incontinence problems. And then urinary diversions, that's a surgical procedure to have instead of an ostomy pouch for bowel function, it'd be a bladder pouch for urine function. For somebody who's completely incontinent, they can do an external urinary diversion. For bowel function, we put them on bowel training programs and put them on bowel scheduling programs. And we give them suppositories and stool softeners at set times. And we change their diet by increasing to high fiber and lots of fluids. Ocular problems. If they get double vision, we'll patch one of the eyes. Now, you have to alternate. You can't patch always the right eye all the time. You have to alternate your patches because it's bad for your eyes just to have one eye forever blocked. But if you have double vision, if you cover one of the eyes, it will help prevent. It's because they can't focus. Both of their retinas are doing their individual things. We want them to be involved in support groups, stay active, because depression, if you stay at home, cooped up in the house, staying in bed, not doing things, it promotes more depression, right? So getting them involved, talking to other people, doing activities they like, staying active is very helpful. We can put them on antidepressants and we can refer them for therapy as they might need to, but It's very, very good to get them out and doing. Nutrition, swallow precautions, very important. Late in the disease, people sometimes need feeding tubes if they're having a lot of problems with aspiration. PEG tubes, remember I said they might need feeding tubes. They're having problems with aspiration. Here it is. So you guys know when you have a patient with a feeding tube, right, around the site, you have to make sure that that site is healthy, clean. Sometimes there's gastric acids or fluids that leak onto the skin and can cause damage. Plus the wear and tear, that catheter rubbing sometimes causes skin damage. We want to secure the tube so it isn't flopping and flopping around. Check residual volumes before you do tube feeding. What does that mean? See how much is left in the stomach, to make sure they're digesting as much as they're supposed to be. What's the number you hold or delay the next feeding for? Most books say 90 to 120. And then if it's 120, you'll hold the feeding until the residual goes down. And notify the provider that's done the prescription that they're on, because you want to make sure that they're digesting what you're giving them. Head of bed up 30 degrees after feeding. If you put a large amount of volume in someone's stomach and then you lay them flat, aspiration can really, if it wasn't an issue, it can become one, right? Always assess bowel sounds in the abdomen when a patient's on tube feedings. And tube feedings can be continuous or intermittent. Patients that are up and moving around with a feeding tube, they're more likely to want to do intermittent, right? I'll feed myself a couple times a day like I do breakfast, lunch, dinner, snacks. But if it's somebody's on bed rest or in long-term care, it might be continuous tube feeding where they're always getting just a slow drip, especially those who have trouble with absorption and digestion and need it slower. And then you always want to keep no matter what, when you have a feeding tube, after feedings or several times a day with continuous, you want to flush that tube and make sure the tube stays patent. Tube feedings can turn to concrete if you're not careful and keep them flushed out. Not real concrete, it hardens and gets, plugs up stuff. So if somebody's having an exacerbation and they're having trouble with balancing gait, let them lay down, go to bed, it's okay. Usually, even if they can't walk, they can still turn themselves in bed and reposition. Bed sores aren't so much of a problem, but we have to let them rest for that few days to a week to heal, to begin to remyelinate. So safety measures, teach them about safety. It's things like cords across the hallways and throw rugs and, all those things that any patient at home, right? And it's hot heat things with the handles turned away from the edges and bath temperatures on the water heater set appropriately, all that. You learn safety till you're blue in the face in semester 1 and 2, don't you?
Yes.
I think. Okay. Please don't turn blue in the face. That's called cyanosis, and that's a whole different problem. All right. Make the patient aware and monitor them. Ask them every time they come in about pain with urination, frequency of urination, spasms in their muscles, falls, all those kinds of things. And then bowel and bladder training. And the biggest thing is keep them up, responsible for themselves, making their own decisions, doing their own thing, doing what they like. As much independence as they can possibly have will promote an optimal level of functioning. All right, regular exercise, we talked about that. Balancing activity with rest. Assistive devices, again, walkers, braces, canes. It's a little repetitive, I'm sorry. It's just I had to put all those interventions together. Speech therapy, fatigue, stress. Overheating, extremely important. Chilling is over real extreme colds can make you exacerbate, but it's extreme heat that's the real problem, okay? And we tend to keep people a little bit cooler, but don't let them get frozen. You don't want to take them up to the ski slopes and take away their coat, but we don't want them to be overheated is a much bigger problem. Much. Let's see, balanced diet, low fat, high fiber. We want them to eat a healthy diet. We want them to gain weight excessively because if they're overweight and they begin to have coordination, gait, and strength problems, that's just more girth to carry around, right? If they become an adult onset diabetic, then what are the paresthesias from? MS or diabetes, right? So what's our comorbidities become a problem. If you have diabetes, you mentioned it. Can I give you high levels of glucocorticoids? I can, but it's going to play chaos with your blood sugars. All right. Sensory loss causes major safety concerns, vision, hearing. They're all neurologically connected and controlled. So any one of them can go away, and so they can cause health problems. We talked about heating pads and bath. We didn't talk about heating pads, but we talked about bath water features. If you have paresthesias and numbness, a heating pad can become a burn source, right? So you do want to make sure that you always cover your heat sources so there's no direct heat on the skin, and that you limit the amount of time, so maybe like 20 minutes on, 20 minutes off, or an hour off, and 20 minutes on again. Scatter rugs, assisted devices. Teach them about their meds and self-administering. And the National Multiple Sclerosis Society has all kinds of help. They can help pay for medications. They can help facilitate all the social support systems these patients might need. Rides to things, therapy. They can help get assistive devices covered by insurance. If insurance doesn't want to cover it, they have donations and things that you can help. All kinds of stuff they can get through the MS Society. Which of the following symptoms do you expect to see in the patient with primary progressive multiple sclerosis? So they got an exacerbation and it's continuing on. Do you expect them to have unilateral vision loss? One eye.
No.
Not usually. It's central. Fatigue.
Yes.
Diarrhea.
No.
Constipation. Tremors. Intention tremors. What does that mean? I shake when I go to do something. It's a Parkinson's thing. It's not always an MS thing. They tremor, but they don't always intention tremor. Paralytic ileus, do you expect it? No. The paralytic ileus is post-op, but yeah, when you have the lack of bowel sounds. You can get that from trauma, but MS doesn't typically cause it. Fatigue, always. Intention tremor, maybe. Those are, if I'm getting answer 2, those are the 2 I'd pick. But
A, B, and D on the
unilateral vision loss. Not usually, but I guess it could be. It's your retina. I gave you the answers, and that's what I said. Okay. I gave you the answers to that? Oh, it's in the notes. I put it in the notes. Patient's diagnosed with MS. You're teaching her how to reduce muscle spasticity. Which of the following statements, if made by the patient, would indicate the need for further teaching? Which means she didn't get it, it's a wrong answer. Right? So which one is wrong? Daily exercise and weight bearing helps relieve spasticity.
True.
My stretching can help with spasms.
True.
Taking baclofen helps relieve painful spasms in my legs.
True.
At the end of each day, I should take a nice hot bath.
No.
No, definitely not.
Good.
Not.
My patient with MS, a patient with MS, says, after I started taking my meds, I feel nauseous and fatigued. I'm running a fever. Looking at the chart, you see that they're on interferon beta 1B. What's your best response? We're going to stop it immediately. You're having an adverse reaction. It would probably be best to admit you to the hospital. You need to be on corticosteroids. This is a side effect. It will go away eventually. Taking your medication at bedtime with Tylenol may reduce these symptoms.
Yes.
That's the best answer. That's the best answer. You don't say, oh, it'll just eventually go away. It likely will improve the longer they stay on the med. That's kind of the way they've said that is kind of discounting their concerns, right? You want to address their concerns and help them to deal with those flu-like symptoms now. See how easy this is? You guys are head straight for great scores. Nurse is assessing a 40-year-old client with MS. Which of the following symptoms would the nurse expect to find? Vision changes.
Yes.
Ataxia.
Yes.
Flaccid muscles.
Yes.
No.
Spastic muscles. Yes. Flaccid, not usually. Butterfly rash.
No.
That's lupus. Slurred speech.
Yes.
Possibly.
So A, B, D.
ABE. ABE. There's my references. We'll stop.